And as soon as birth happens, the healthcare team is ready and they jump right into the very extensive levels of neonatal care that we provide at Canadian hospitals. One of the very first psychological tests that a neonate endures is the Apgar scale. The Apgar scale is a very quick assessment of the viability of the infant. For the Apgar scale, we're looking at 5 characteristics and rating each on a 2-point scale. The max score you can get on the Apgar scale is 10, and any score beyond 7 is good. Scores around 5 show that you're at risk, and scores of 3 or less show that there's emergency and the neonate may not survive birth. And so the first scale we want to look at is the appearance. If the infant is blue all over, that's 0 and that's an emergency. Or if they just have blue hands and feet, that's a 1. That's showing that they just don't have the good circulation to their hands or feet yet. Or if they are pretty flesh colored throughout, that's a score of 2. The Apgar scale has been criticized because it may not show the risk, some subtleties of blueness throughout the body in babies with dark complexion. But some nurses have known that if you just check under the tongue or check in the mouth, if it's blue there, then you know you have the emergency with babies with dark skin complexion. The second thing is pulse. We want to check the heart rate. And so if it's a good pulse, that's a score of 2. A weak pulse that's present is a 1, and no pulse is 0, or an emergency. Next thing is the reflexes. If the infant comes out of the womb crying, hiccuping, coughing, sneezing, all of that scores a 2. If there's none of that, but they kind of grimace and respond that way, that's a 1. And if there's no response to their environment, that's a 0. Then there is the activity. Are they moving their arms and legs? Do they have good, strong muscle tone? If they appear strong, that's a 2. If they're moving but they appear weak, that's a 1. And if they're flaccid and they're not moving at all, that's a 0. And finally, there's respiration. And we can usually tell this again with a cry. If they're breathing at normal, that's a 2. If there's a weak breath, that's a 1. And if they're not breathing at all, that's a 0. And so the Apgar scale is where we detect right away in the delivery room how at risk this infant is and if they're going to survive. And if they're at a 7 or above, then we know that they're pretty good and they're pretty robust and we think that they're going to make it. In addition to that, the testing continues over the next couple of days. In the hospital, in the maternity ward, typically, we undergo a lot of neonate screening. There is the heel prick test. This is when we prick the heel of a neonate, get a little bit of blood, and we do all the genetic screening. We also test them for jaundice. This is making sure that their liver is processing toxins properly. And if it's not, they'll start to get a bit of a yellow complexion to their skin, regardless of their ethnicity. This is usually okay and it usually goes away on its own. In some infants, they just need to get exposed to some UV light or some UV therapy. We'll also stick a device in their ears to test their auditory processing. This is really important because neonates can't tell us that they hear things, and so this little device checks to make sure that their hearing is good. And sometimes even if it comes back not so good right away, some follow-ups at 4 months of age or so can usually come back and say, no, just some water in their ears when they were born. Everything's typical now. And we check their reflexes, make sure they're coughing and sneezing and all that type of stuff. We also are obsessed with checking their digestive health. It's very common for people to make charts of how often they feed, how many wet diapers, and how many dirty diapers they produce in the first day or 2 or 5 of their life. And as things continue on, we start to look at their developmental milestones, which we'll talk about in later units. Now, some infants are born not doing so good, and we know there's certain infants that are more likely to be at risk. For instance, we know infants that are born as preemies or preterm infants. This refers to infants that came early, before 38 weeks in gestation. And so what happens here is if they're born around 32, 28 weeks, they're born with their systems not as mature. And so because of this, they may need extra help with breathing, digestion, temperature regulation. And we know that if an infant's born too early, let's say 23 weeks, they may have a very low chance of survivability. It's because of this we need to make sure we're providing adequate care to our preterm infants to get them up to speed. In addition to preterm infants, we may also experience small for date infants. These are infants that maybe are born at full term at 38 weeks, but they are really small for their age. We know that the average baby born in Canadian hospitals is somewhere around 7.25 or 7.5 pounds, and that 70% of babies are born between 6 and 8.5 pounds. So if a baby's born, let's say under 6 pounds, that lets us know there might be something atypical with this baby. Because they're atypically small, maybe they're at risk for atypical development. Some babies are typical, just small. but it might be an indicator and a red flag of something more. We can also get a baby that's both preterm and small for date, in which case they might be born at 32 weeks and they were small for fetal growth at 32 weeks, in which case it's a combination of both those risk factors. And finally, we might have babies that regardless of when they're born at extremely low birth weight. Anything less than 3 pounds is considered a miracle, and they have to give extremely extensive interventions. Luckily for these at-risk infants, our interventions are getting better every day. In terms of some of our interventions, almost all major Canadian hospitals now have what's known as a NICU, or the Neonatal Intensive Care Unit. In the Neonatal Intensive Care Unit, preterm, small for date, or extremely small babies are placed in incubators. Not incubators like the egg incubators, but incubators that help them through feeding tubes and breathing tubes and keeps their body at a good temperature. And we also know that there's other characteristics that can help them to thrive. And we know things like infant massage can help these babies. Not a massage where you need to do deep tissue or get out the essential oils, but just touching the baby's body. We know that babies really respond good to just a light sensory touch. And this helps to mature their peripheral nervous system. It gives them that nervous system sensation that helps them to mature and grow. Especially if they're not preterm, but they're just small for date, this can help them get a growth spurt. In addition to this tactile stimulation, things like auditory stimulation, reading stories and singing to these babies can help. It helps to mature and specialize their brain areas. And finally, there's this notion known as kangaroo care, which is essentially just cuddling and keeping these babies in little pouches. And what we find is this tactile stimulation through cuddles actually saves lives. It can actually help these at-risk babies to thrive. And so kangaroo care is this idea that we, through cuddling and through this tactile stimulation, we're helping through not just the touch, but through the hormones released through our skin and absorbed by their skin. There's wonderful research on the skin-to-skin miracle in helping babies to adjust to the world outside the womb and to grow. And so neonatal care is fascinating, and it's in response to what went on in our prenatal development and response to what happened in the birthing situation, and it is what sets us on the road for the rest of our development. Congratulations for making it to the end of our longest unit of the semester. This is very long for me to record as well. You've now made it to the end of Unit 2. Well done.